Tonight, we're going to be exploring the pros and cons of universal publicly funded health care, also called single-payer health care and sometimes Medicare for all. My name is Henrietta Jordan, and I'm going to be your moderator. I'm a member of Northern New York Citizens for Better Health Care, and we're not really an organized group. We're kind of an ad hoc group of advocates and consumers who got together after the town hall forum that was held right in this room back in February. Our goal is to help everyone better understand various issues related to the health care we get for ourselves and for our families. Most of our group is here tonight. Please stand when I call your name so people can recognize you. Sarah, can you stand? All right, Sarah Carpenter. Lindsay Quillen, is Lindsay here? Hi, Lindsay. Okay. Eva Lau. Eva may still be outside at the table. Hi, there she is. Okay. Stephen Barada, is Stephen here? Okay. There's Stephen. Hi, Stephen. And then Martha Devaney. Okay. Now, we as individuals may have political affiliations with one or more political parties, but tonight's presentation is strictly nonpartisan. This is not a Republican issue or a Democrat issue or a Green Party issue. This is a human rights issue. And we are not by any means the only group in the North Country working on health-related issues. Jack Carney, Jack, would you stand so people know who you are? Jack Carney of Indian Lake heads up the North Country Access to Healthcare Committee. What? Long Lake, I'm sorry, Long Lake, sorry, I got my legs confused. Of Long Lake heads up the North Country Access to Healthcare Committee, which is organizing efforts to pass the New York Health Act. And there's also a group, the New Resistance, led by Agatha Stanford. I don't know if Agatha is here tonight, but they also held a wonderful forum on health care just last month. And there are numerous other groups that are organizing locally by educating people and inspiring them to act. We, in our group, are certainly honored to be working alongside them and augmenting their efforts. As I said, this is the first of a series of presentations. Hopefully you all got a card when you entered, a feedback card, and we hope that you would indicate on that card which topics you would be most interested in for future presentations and whether you might be able to assist with them. We also have a Facebook page, which you can find by searching on Northern New York Citizens for Better Healthcare. And we hope you'll join that so that you can post comments, suggestions, announcements, news, and read the posts of others. Okay, so tonight we're going to be focusing on the pros and cons of a single-payer system. But before we get started, I want to make sure we all understand what we mean by the term single-payer. A single-payer system is a healthcare system in which health services, hospital care, outpatient services, physician services, etc., are delivered by private entities, just as they mostly are now. But the cost of these services are paid through a public entity, and the patient doesn't get a bill for them. Original Medicare, Part A and Part B, is mostly a single-payer system, but of course Medicare Advantage is not. A government health system such as the Veterans Administration and the National Health Plan in England is one in which the care providers work for the government. In other words, the care is not being provided by private entities like local hospitals or private doctors' practices. The care providers actually work for the government. We have a system like that in the United States. It's called the Veterans Administration. But what we're talking about tonight is not a system like the Veterans Administration that is publicly financed and publicly delivered, but a system that is publicly financed, yes, but privately delivered. We're going to start tonight by showing a 35-minute film entitled Now is the Time, which highlights the problems of the healthcare system we have now and discusses how a single-payer system would remedy them. I would like to observe that although the film enthusiastically recommends implementing a single-payer system, we hope our panel and you in the audience will address the cons as well as the pros. If the United States, or even just the state of New York, were to implement a single-payer system, we need an educated citizenry that knows exactly what it is getting and how this system would be better than it is now. The panel discussion following the film will focus on two pieces of legislation. H.R. 676 is a bill that has been introduced in the U.S. Congress, and I have a fact sheet about it up here on the table. After the presentation, feel free to come back and get the fact sheet. The other bill is the New York Health Act, which would implement a single-payer system in New York, but not in the rest of the country. The New York Health Act has been passed by the Assembly and is awaiting action in the state Senate. Our state senator, Betty Little, has not yet signed on to the bill or indicated that she supports it. If, after hearing this presentation, you would like to advocate for passage of the federal bill, contact Congresswoman Elise Stefanik and urge her to support it. If you want to advocate, well, at least you both try. If you want to advocate, I mean, you know, it's funny too, because I think, Elise Stefanik, poor Elise Stefanik has been getting such bad press lately, and everybody in the district is like, if she would only sign on to single payer, she could reverse all that. But anyway, she didn't ask me. But if you want to advocate for the New York Health Act, contact State Senator Betty Little. I have to say that, in my opinion, and I think in the opinion of many, we have a much better chance of getting a New York Health Act passed in the next few years than we do having a single-payer bill passed by Congress. While we're getting the film started, I would like to ask each of you to do one thing. Please look around you and find one person you do not know, sitting next to you, behind you, or whatever, and just introduce yourself to that person and tell him or her why you are here. And then we will start the film.
Welcome. Your concerns matter to us, and you can count on us to help. Did you call to pay your bill?
We have come across the country to do a project, and I ran into some medical issues here.
There's really not a lot in Maine for your particular condition.
It's very easy to get stuck in this idea that just having insurance is the end all and that's it, and the conversation stops.
Well, why should we assume that a for-profit company will provide good health care?
So people are underinsured, and if you go out of network, you have to bear the whole cost of the health care yourself.
What we're doing is taking our dual system of Medicare and Medicaid and making it into one Medicare for all plan.
We want the New York Health Act to pass. We want single payer. And we're not alone.
Virtually all economists, I think, would say that if we could go to scratch, what system should we have? Of course we should have single payer. It's definitely more efficient, provides better care, less expense. They follow that with a but. We can't do it politically.
I mean, we're talking about a radical position that is the most conservative financial position, and that is for the government to fund, not control, health care.
It's very easy to scare people with taxes.
You know what? We, by law, are required to buy health insurance. That makes our premiums a tax.
And the truth is, we pay the highest healthcare taxes in the industrialized world. 64% of our healthcare dollar is already funded by taxes.
Everyone has to deal with a broken healthcare system.
98% of all New Yorkers will pay the same or less for healthcare.
98%.
98%.
And all for one. Will someone please help me see why it works all around the world but won't work for you and me? I know healthcare is big business, a big business that's quite healthy, but does it care about your health or making its investors wealthy?
Okay, as I mentioned at the beginning of the presentation, we have some fact sheets from Physicians for National Health Plan. This is about HR 676. Excuse me, this is about HR 676 from Physicians for National Health Plan. And then the other two handouts are about the New York State Health Act, the bill that just passed the Assembly for the third time and is now awaiting action in the state Senate. That is the bill that we want to talk to Betty Goodall about. So, anyway, I'm very pleased to be able to introduce you to this very distinguished panel. We have here George Jolly, who is a retired physician, and what was your specialty again?
Internal medicine.
Internal medicine.
Interior.
Okay, and George has done a great deal of research about the impacts, the cost impacts of the New York Health Act that would accrue to businesses, municipalities, governmental units, school boards, etc. And he's going to tell you a little bit about them. And I encourage you to look at his posters, which are at the back and the side of the room on your way out. We also have Dan Larson, and Dan has been, Dan is the medical director of Hudson Headwaters Health Network. Okay, and what can you tell a little bit about? I mean, are you a practicing physician as well?
Yes, I am.
Okay, and what is your specialty?
I'm a family doctor, and I'm a half-time bureaucrat, if you want to call me that, or administrator at Hudson Headwaters.
Okay. And then we have Andy Coates, Dr. Andy Coates, and you are with Physicians for National Health Plan, but you have other roles too, right?
So a couple of years ago, I was the president of Physicians for National Health Program for the United States. And since then, I've been working at Albany Medical Center. I'm a hospital medicine physician. I'm a teaching attending in medicine. I'm also board certified in hospice and palliative medicine.
Okay, so we're going to start with some short presentations by Dan, and then George, and then Andy has said he has a lot of kind of anecdotes and things to tell, but what we mostly want to spend our time on are your questions. So if you haven't yet written down your questions for our panelists, do so now so we can get to as many of them as possible. So would you like to start?
Sure. Can you hear me all?
Yes.
I'll be much more brief than I was going to be because the movie stole a lot of my thunder, which is good. I would say we clearly, practicing physicians, acknowledge that the Affordable Care Act needs a lot of fixing. There's no doubt about that. Whether it's fixing around the edges, that is an incremental step. I certainly am very sympathetic and would hope for the huge fix of Medicare for all, whatever you want to call it, single-payer health system. We need a bigger fix. We're accused of reading the literature from just the side we want, but there have been a lot of articles in the New York Times and the Wall Street Journal pointing out the competitive advantages that American businesses would have if we weren't spending this much money on health care. The healthcare premium for a Hudson Headwaters employee for a family plan is $14,300, and we self-fund all of our own primary care, and we self-fund the first $1,500 of a $3,000 deductible. So we have a total of $1,500, and it's still costing us $14 grand for a family plan, and a little shy of $6 grand for an individual plan. The point that was made in the movie, you can get a lot of payroll tax, you can pay a lot more tax and still save money by not paying that premium. I won't go into all my stuff I was going to do on the percentage of GDP and the per capita. I think the movie did it pretty powerfully. It is interesting that we pay about $10,000 per person. The next two most expensive countries are about $7,000 a person. That's Luxembourg and Switzerland. And most of the other countries are about $5,000 a person. And we do not have the best healthcare data by any means. I think Hudson Headwaters' growth has proven that the current system does not work for the patients, and it doesn't work for the primary care doctors. We've grown astronomically. In 1988, we were 6 doctors and 6 PAs. We're now about 90 of each. And it's not because we're so great. It's because the rest of the practice environment in this country is not very appealing for primary care doctors, and the patients are finding that the insurance system is a mess. We're a community health center. That's not perfect, and we're quasi-public but quasi-private. We do okay. Hudson Headwaters does okay under the current system. We would do better under a national system, but most importantly, our patients would do better. Our patients who have the $5,000 high deductible plan when they're making $38,000 a year. How do you afford that? Anecdotally, I think all the data in there about the insurance profits and was powerful. And I have a good friend who's a vice president of Aetna, so I get the other side of it. The prescription costs are astronomical, and our proximity to Canada makes that evident to me. Almost every day in the office, somebody asks me, can I get that in Canada? Colchicine, a common gout drug, was 3 cents a tablet until a couple years ago. A clever lawyer now patented it. It's now $3 a tablet. It's still 3 cents a tablet in Canada because I have purchased it there myself. Voltaren gel, common simple thing. $75 here, $18 over the counter in Canada. If you want to go for the vanity ones, the Cialis, the dual bathtubs looking over the Pacific. I wrote this one down, $340 for the daily Cialis for a 90-day supply here. It's, I think it was $101 in Canada. And there are innumerable examples. So the prescription drug prices, and again, the VA and the Defense Department bargains for drugs. The rest of America doesn't. And originally, Donald Trump and Hillary Clinton both agreed they would bargain for drugs. I'm not sure Hillary would have followed through. Donald clearly has not followed through. And one thing, as a long-term previous Connecticut resident, I'm still embarrassed that the deciding vote against the public option in the Affordable Care Act was cast by Joe Lieberman. The deciding vote against the public option. Now, public option is not quite the same as single payer, but it would have been a heck of a good step. And so I was just aghast at that. So I think the movie said most of it. I'm going to just pass the microphone off. Is it going to George next? Is that where we're going? Yes.
Hello. Okay, here I am. Well, so I've been interested in the single payer for a long time. And 10 years ago, right before the ACA, I started to do some financial modeling to see if how HR 676 would play out in terms of the local costs. And that's how I got into it. I must say that I am so heartened by seeing you folks here, by seeing the level of interest in the media, but mostly in our local communities, and finding out about this issue of healthcare finance. that in order to make a change, we're going to have to learn something about it. So I feel like the mood is very different now than it was 10 years ago, and I'm heartened by that. 10 years ago, the drug companies and the insurance companies wrote the Affordable Care Act, and they wrote the Medicare Part D laws. Mentioned in the movie. And so it's not surprising that those laws really entrench those corporate interests. The gridlock in Washington, again, as the movie said, has resulted in states looking at the single payer, looking at better options. And so I am very, very hopeful that we'll be able to, make progress, in spite of the fact that there are lots of hurdles. Remember, California passed, the legislature there passed single payer a couple times, was vetoed by the governor a couple times. There are many states working on it again. I don't know what's going to happen if we get it through the New York State legislature. I began asking myself, well, how can I be useful as a citizen in dealing with this, to getting us to think about the single payer thing? I mean, I'm not a legislator, the times I'm not really very, I write letters, but it wears me out. It's very hard to keep up the energy of going to protests and the communication. I've always been very grateful to Andy's organization, because it's been, it keeps me on track when I feel like I'm losing it and losing my energy. The Physicians for National Health Plan. But the strategy I've chosen recently was to try to expose and educate local officials, local government officials. See, and what I'm thinking is that our town boards, our county board of supervisors, our school board members, these public officials are part of political networks. The networks these networks that they're involved in really go two directions. They have connections with people in Albany and people in Washington. They also set the conversation in our local governments and our local public institutions. So I said, making sure that this group of people understand what single payer is, and have at least heard it, so that it's not, they can't just say, I don't have a clue what that is. So what I did was I used some very simple tools, my Excel spreadsheet, and I went online, and you're able to find salaries for public institutions, for counties, schools. All the salaries are listed there. And I took the Gerald Freeman's proposed tax brackets and tax rates, and applied what they would be like to those salaries in our governmental institutions. Please remember that the tax brackets and tax rates have not been written into the New York Health Act law. The law specifies that it'll be graduated payroll and taxes on under income and payroll. It also specifies that the governor will be responsible for coming up with a financial plan that will support and pay for all necessary medical care. Okay, so what has to happen is that we have to, it has to become law, and then we're going to see the wrangling over the details and how it's paid for. Gerald Friedman, this Massachusetts charming guy in the movie here, modeled and made some good suggestions with some assumptions, and those are the model, those are what I use. And I do hope you'll stop in front of those posters back there before you leave, find out the governmental entities that are related to yourself. Because every single one of you has a school board that you're involved with. Do you have a county that you're involved with? Do you have a town or a city that you're involved with? You might even have a village. And those numbers are can be calculated for every one of those entities. You know, I have this vision. If a bunch of activists in every school district and town across New York State, if 2 or 3 of them got together and presented at their public hearings and said, we could save this amount of money if we had a different kind of health finance system. And I'm encouraging everybody here to think about participating in that kind of a project. I have a clipboard here that if anyone wants to leave me their name and their email address, I will send you an instruction sheet on how to get that so you can make the calculation for your local governmental entities. And we can do this. And I'm encouraging everybody to participate and do what they can.
Yeah, I'd just like to add that, I mean, when George first showed me his spreadsheet and how one could use them to calculate the expenditures for villages, towns, cities, counties, and school districts, my first thought was, what happens when these entities are able to reduce their spending? My taxes go down. My school tax goes down, my county property tax goes down, and my local property tax goes down. So in addition to the savings we would realize as individuals under the New York Health Act, there are significant savings we would realize as taxpayers.
One of the big categories I didn't mention was these are really minimal kind of things. For instance, I didn't include anything about workers' comp medical costs and these and other. Counties in New York State are responsible for about a quarter of all Medicaid costs in the country. And for New York State, the counties take over about a quarter of those costs. For Saratoga County, one of the administrators just told me 2 days ago, $24 million in Saratoga County annually. And my calculation was that in terms of staff healthcare costs, they'd say 19 million. But you see where the numbers are going? They're going out through the ceiling as to the potential savings.
Some terrific work, and it's incredibly powerful to try to think about what this kind of a transformation would actually mean in our own communities. You know, my parents live in Greene County, New York, so it's one of the counties without a hospital. I think it's like Washington County now. And if every patient's care were compensated to the providers, that those counties could again have a hospital. Or Hudson Headwaters could help figure out how to better serve the underserved because there would be total reimbursement. So it would be very liberating for the community. And then there are economic analyses that are not done. So in other words, would you like to use a Keynesian multiplier effect? If you built a hospital in Washington County again, or a facility that had an emergency room and associated specialty clinics, wouldn't that mean steelworker jobs? Wouldn't that mean carpenter jobs? Wouldn't that mean a new restaurant? And so on, because healthcare is such an economic driver. We're not talking about reducing the total cost of healthcare spending. We're talking about taking the middleman out of the game. Profiteering has no place in the care of ill human beings. And so if we took that profiteering away and put it into the care of patients, we could do something like we should be doing for the health system. And it's my feeling, I'm going to stop because I really look forward to Q&A. done this for about 15 years, many medical grand rounds, very good news. The medical societies of Onondaga County, Essex County, and Clinton County recently all invited me to give our grand round style presentation about the physician's proposal for a national health program. Very good news that those doctors are thinking very seriously about the next step for the entire system. And I would say it was welcomed at by all of those participants. I can testify that in those meetings, the majority of doctors are for single payer. What I was going to say is that, I really look forward to trying to answer questions, especially the hard questions about what this would mean. Our method has been to try to stay within the science. So it turns out that if you try to take a profit out of caring for another human being, it is more deadly and more expensive. And there are a handful of studies, very elegant studies, done by a cardiologist who's an evidence-based medicine expert in Canada, that show that if you take a dialysis center and make it a for-profit game, and most dialysis in our country is now for-profit, it is more deadly and more expensive than a not-for-profit dialysis center. And then there are associated scandals that go with all the gains that the profiteers make. Same as for nursing homes, same as for hospitals. The evidence says that profits have no place in healthcare if we want the best outcomes. When it comes to decisions made by patients and their physicians, what we don't need is a middleman, whether from the government or from a private insurer, coming in between the caregiver and the patient and trying to tell us what we're allowed to do. The best quality is going to come when we make that decision together and have a mutual agreement about the best way forward. It really becomes the best way that things work. And you can turn to the healthcare evidence for this. When you look at user fees, the healthcare policy term is user fees, co-pays, deductibles, coinsurance, cash at the time of service. It discourages people from seeking necessary care and makes the population less healthy in aggregate. User fees are very bad public policy. And these are the kinds of ideas that come out of studying the question. So the question then becomes, can we use health science and social science to guide health policy for a healthy country? And I would go one further and say, isn't that the meaning of a modern democracy? To have a guarantee of the best possible health care for all of the people in the democracy. So,
Okay.
Yeah, this is Ethel Eisenberg. I'm an old person, and I want to try to convince other people that single payer is a good thing, and I want to know how to do it. I think that you're going to say to me that the people who are not for it need to be educated, and I don't disagree with that. But I think that I get the sense from this movie that if I convinced everybody, it still wouldn't go over. So I need to go higher than the average citizen. I don't understand why the average citizen doesn't go for single payer. So I'd like you to comment on that if you can, and give me any ideas that you already have about how to convince people.
All right, so this is really the question, in my opinion. How else have major reforms been run? One, this is an incremental reform. It would liberate a whole lot of people who now have a dead-end job because they have an ill spouse, and that spouse gets their health care access through their husband or wife. People who worry about their children or their parents and make life-altering decisions. We know that in end-of-life care, the vast majority of personal care at the end of life is provided by immediate women family members for no financial compensation, but it's worse than that. The consequences are that those women often lose their jobs because they have to be at the bedside, and then they have financial ruin on top of the indignity of caring for their father, mother, aunt, whoever it happens to be. And so all of that, ending all of that indignity in our system would be a major, major change, but it would be a reform. We could still have two parties, you know, that run everything. We could still have corporate capitalism and finance capital running Wall Street. We could still have factories and the farms with migrant labor over 50% of our farmers now. I think that it's a reform. So how have the reforms been won? How did the civil rights movement win? It took enormous courage and determination. I think from 1848 to 1919, you know, that's an awful long run for the women's suffrage movement. And we're beginning to feel much the same, you know, because we can look back to people who in 1910 began to propose national health insurance for the United States. We can look back to 1948 when Harry Truman really pushed it forward. That's an awful long time ago. So 1948 to 2017, that's 100 years later than the suffrage movement. So how will change happen? Well, it's certainly not going to happen through the institutions as they're working now, because they're not working now. We're in an enormous, enormous crisis. It's not working for the rich, because they're darned if they're going to give any money back to the poor right now. The idea of taxing the rich is looked at as a scandalously left-wing idea, when it used to be that the wealthy were proud to pay taxes because the country had made them so wealthy. And for the poor, things are really, really tough. The median income of the poorest half of New York State, so you take the bottom half and you cut it in the middle, was $16,000 30 years ago per household. Now it's $14,000 in the real dollars. It's gone down, and the poverty is unbelievable. And I see it in the hospital because we have patients at Albany Medical Center from all of New York State, to the Canadian border, to the Pennsylvania border, out to Syracuse, into Vermont. And when you take a proper social history and understand what kind of income is coming into the household, it's shocking. So it's in that kind of social problem that we're coming. And I think it simply takes the courage to build a movement. So George has his tactic. This is a brilliant tactic. He's put together all of this data, what it would mean to Washington County, Saratoga County, the town of Greenwich. You know, he's looking at exactly what it would mean in terms of changing the tax structure locally. That's his tactic. So this is creativity that, you know, Dr. Jolly brings. I'm going to tell you, you have to bring your creativity, because the way we'll build a winning movement is when everybody brings what they think will work, not what I tell you works. You know, it's when everybody brings what they think will work. So in the end game of women's suffrage, you know, women drove their automobiles across the United States in this daring display of personal independence, only to advertise for the cause. They got fed up with the Democratic Party president, Woodrow Wilson, and they ran campaigns against him in the states where women could vote. They took on the whole establishment. The war broke out. They were picketing the White House. They were told they would be unpatriotic if they continued picketing the White House. They kept picketing the White House. They got thrown in concentration camp style prison in Occoquan, right? The courage of building a mass movement with their creativity. And I think that that's a kind of picture of what social change will take for an idea as tame as this. This is the most tame idea. Yeah, sure, liberal benefits. Everyone should have the same access to excellent health care. But conservative spending by far. Even the Republicans in the most recent period have been saying that the problem with healthcare costs is that the health insurance risk pools are not large enough. Congresswoman Stefanik, you didn't make it. But if you are here, Congresswoman Stefanik, if you think that the larger the risk pool, the more efficient that payer system will be, we agree. Why not have one risk pool? Everybody in, nobody out. That's the idea. So it's a very, very conservative idea. And so I think that one of the challenges I'm kind of getting at is to figure out how to talk about this in a way that's nonpartisan. And I really have no trouble, because in my opinion, the worst opponent of single payer, the fiercest and most powerful opponent has been Hillary Clinton. Not going to happen, she said during the campaign. In 1993, when she had my organization, I wasn't even a physician then, but the people that founded our organization to the White House, they presented the thing on single payer. At the end of the meeting, they said, we've talked about it, we're not going to talk about it anymore. Why not? To tell us how it's going to happen. Well, Dr. Himmelstein says, perhaps the President of the United States could lead a crusade on behalf of the health of the American people. David, tell me something interesting. Right? So I think that the Democratic Party establishment really doesn't want this any more than the Republican Party establishment. And what it reminds me of is, you guys all know who Tommy Douglas is? A very sophisticated group, right? Tommy Douglas? No. The founder of single payer in Canada. He was the premier of Saskatchewan from the Canadian Commonwealth Federation, which was neither the Democrats of the day nor the Republicans of the day. It was a farmer-labor party, which maybe is something else about the kind of power that we need to win this. But Tommy Douglas used to give a speech, a famous speech about, there was once a place called Mouseland. And in Mouseland, every 4 years, they would go to the polls and elect a leadership. Every 4 years, they would go to the polls and elect a cat. And the cats made good laws for cats. For example, the law would be that the mouse hole had to be big enough to get a paw in. And so one day one of the mice said, well, maybe we should elect a black cat. And so they did. And the black cat ran on a program of making square holes. And now the cats could get both paws into the mouse hole. And this kind of idea that you need to be independent of this whole thing and say what we want our country to look like was very powerful then. And I think it's becoming very powerful now. And I think that in the moment that we're in, this is the discussion that many, many people are having. And I'll just go one further. I don't find this discussion to be something that's all that controversial, that you need a lot of courage to go into, because the idea that we would have a system designed to leave people out of healthcare, and we all have these stories in our families and friends of people who have been unjustly cheated out of the best possible care. I think the idea that everyone should have access to the same best quality care is already won. And so we just need to figure out how to build a movement to make it happen. So, sorry for the long answer.
Let me give a much briefer and less eloquent answer, but I do believe that part of it is persuading the elites, certain key elites, who can then persuade the representatives in government. As that graph showed, when the bottom half of society wants something, it doesn't change. When the top part of society, it does. So if we can persuade some local captains of industry, to use that expression, maybe some courageous school superintendent who's nearing retirement and is not afraid of being canned. If we can persuade those kind of people, particularly some business leaders, because we all know that mom and pop startup businesses, George made this point earlier, mom and pop startup businesses, which are plentiful in Warren County, they can't make a go of it, because you can't give up your health insurance with an employee position to start your own. You can't afford to do it, and you can't afford to hire the employees. But if we could persuade the heads of the biggest employers around here that this is a good idea, they might be the people who could persuade the Representative Stefanik on a national basis, or the Representative Little, Senator Little on the local basis. Those are the people, I think, that are best bet.
You can see from what I said that I struggled with the same question: is how can I, as a citizen, be effective, given my own limitations, and, family, and whatever thing? How can I do something that's useful? The fact that you came tonight, you're right on. Okay, and this applies to every single one of you. You're taking this seriously and trying to build your concept of what it's going to take to make a change. Second thing is, I'm talking about going to public meetings. It's scary to go to a public meeting. It feels kind of overwhelming. But if you go if you partner with somebody else, hook yourself up with other people that are interested. Look around this room. Don't leave this room without somebody's name, and say, I want to have somebody that I can check in with about this, that we can plan a meeting, that we're going to go to some public event and make a public statement. We're going to be there together, and it's going to feel doable because we're there together.
Okay, hi, my name is Steve Barada, and as some of you in this room know, I will tell it to anyone who will listen to me that I was diagnosed with a disease that was deadly 27 years ago, and thank God I'm around today, and it is a chronic condition now, but I still have to take about 14 medications every single day, and at the current tally in 2017, it was $80,000 a year. If I have to add another drug, which probably will happen soon, it will go up to in excess of $100,000 a year. Everybody in this room is helping to pay those exorbitant costs. Okay? And then I want to point out HR 676. There are a small group of activists that I've heard talk about the fact that in it, which I wasn't even aware of, that it relies heavily upon institutionalized care for certain portions of the population, mentally ill and developmentally disabled, and that's problematic. I know the New York Health Care Act is kind of vague in terms of how it's going to deal with. They're hopefully going to have to figure out in a certain time frame how to deal with institutionalized care. And then another question that I have is, my understanding of Vermont was that it was more of a directive to see if it could work. Is New York Health Care Act more than a directive? Is it actually legislation saying, okay, we want this, you have to figure out how to make it work? And the other question is Medicare. If we are able to obtain the waiver from the federal government, will New Yorkers continue to have to pay Medicare taxes?
The way the law is written is that the governor is directed to come up with an adequate financing program for all necessary medical care. Medicaid costs go away, Medicare payments go away. The payroll and the taxes on payroll and the taxes on unearned income are what will fund the New York Health Act. And the taxes, well, you say again, those haven't been specified. We've got to keep that in mind. And Friedman's has made some good suggestions that I think can work, but that all has to be mashed out.
I just wanted to start off by sharing some information. There are 3 Republican senators on the Health Committee that are citizens in the New York Senate Health Committee that are opposed to single payer. They're all in Congressional District 21. Talking about Patty Ritchie, Betty Little, and Jim Tedisco. In conversations that my committee has had with these individuals, except for Ms. Ritchie, who haven't made it up to Watertown, the issue of single payer hasn't even been placed on the agenda of the Senate Health Committee. It will not get on the agenda before the end of the current legislative session, which is June the 21st. However, in addressing some of the issues that you raised, and the need to be persistent over a long period of time, some of us are going down on Wednesday to do what we call lightning lobbying, and we're going to visit all those folks. In addition to Kemp Hannon, who's the chairman of that committee, and we're just going to leave them little notes telling them, we're sorry you didn't vote to discharge the bill to the floor of the Senate, but we'll be back next year when, once again, it'll pass the Assembly. But the unfortunate thing is all that has to start again. One question I do have for you is this. By the way, if anybody wants to join us, Wednesday, 9 o'clock, in front of the Legislative Office Building. The one obstacle that keeps on getting stressed, particularly by I think it's Paul Francis, the Deputy Administrator of the Department of Health, that he didn't think that single payer was a go, for the simple reason that he doubted the federal government would ever give the state the waiver to merge Medicare and Medicaid monies. Do you want to comment on that?
So yeah, so I think that's true, that to have a single payer system in a state is very tangled and problematic in implementation. There would be the problem of getting to a single payer, because all of the efficiencies that Dr. Friedman, for example, studies come about when the administrative waste is consolidated into one payer. And from studying other nations, the inefficiencies come as soon as there are 2 or more payers. It's not when it goes from 100 down to 5. It's when there are 2 or more. The inefficiencies start coming in because the hospital then has to have a team of coder billers to keep track of where the money's coming from and whether or not it's being paid, and then each institution has its team, and pretty soon it mushrooms back into the bureaucracy that we have now. So I think that that is a problem for a state-based bill, and you might say then that in order to have a New York single payer or a California single payer or an Illinois, Pennsylvania, to have a state-based bill, you would need an act of Congress. I think that we obviously need a solution for the whole country. I would hate for New York to have very good health reform at the expense of everyone in Mississippi being kicked off Medicaid altogether. Some kind of states' rights nonsense. But on the other hand, activists have to work from where they're comfortable and what they think they can move. And so what you've done, what George is doing, is you're talking to people who you really know. You really know their sphere of influence. You really know their arguments. You really know that when you talk to one of those senators about the prison health care problem that they know all about in their county, they can't afford the health care, and the anecdote that comes with it. They know all about those issues. So you could liberate the county from those problems and think of all the problems that would solve. Never mind getting into the weeds of workers' compensation and auto insurance and other add-on things that might come later. There's a very, very compelling conversation to be had there. And so I think that what I'm trying to say is the same thing, that if you think that this is the way to move us forward, you have to go for it and not worry about it. I'm told all the time that it's not feasible to get H.R. 676 through this Congress. But I turn around and it has more co-sponsors than it's ever had, and we don't have a mass movement that's clamoring for it in a way that would explain that. It's happening because it makes sense. It has the reputation of something that people know will work, which is a funny way for things to come about. It usually comes about because of real hot grassroots pressure, something like this. And yet there are more co-sponsors for that bill than ever before. So I think it's by building this movement that we'll figure out how to really articulate it. I would just add, though, that there are some things that can't be compromised. If we're going to have health planning, we cannot let local institutions control capital budgets. This would be for you, right? So Hudson Headwaters would have to go to the regional authority, like CMS now, and say, you know what, we need a new clinic we need better emergency services in Ticonderoga.
There's an example.
Right? And so therefore, we need a major capital improvement with a big addition of staff in Ticonderoga. Right? And you'd have to do that. And then they would say, all right, you've made a compelling case. Next year, we're going to fund that. They might also say, next year, we're not going to fund that. Because what happens now, I work on New Scotland Avenue, St. Peter's on one end, Albany Medical Center on the other. Over the last years, there have been cranes on each end of the avenue building parking garages for millions upon millions of dollars, probably hundreds of millions of dollars. It has not changed the quality or the access of care. It has built the institutions. When you have that kind of capital and your responsibility is to health, the public should be involved. And so we would say that it must be, and this is in H.R. 676, it must be that there's a public process for capital expenditures. There should be no user fees. I already mentioned that. On principle, no one should have to pay money. Skin in the game is not health policy. It's ideological claptrap that does not apply to keeping people healthy. There's no such thing as skin in the game as good health policy. It's been discredited decade after decade after decade now. So we have to have these principles in the bill, no profiteering. That's why HR 676 would convert the system to a not-for-profit system. In New York, it's a little different because major institutions can't be for-profit already, even though we have the incursion of dialysis and private equity firms owning all the nursing homes and so on. But, so, okay, so, I'm sorry about that. Yeah.
Hi, my name is Robert Ward. I'm from Glens Falls, and you kind of answered a little bit about my question, but I was wondering about state plans versus a federal plan. And has there been any research done on how state plans would fare during recessions and downturns? Because the states have fiscal constraints that the federal government doesn't necessarily have. So I was just wondering if anyone who's done some of the economic analysis has kind of looked at that on the state basis, especially with balanced budget requirements, things like that. Thanks.
George, I don't know the state-based bills generally look at aggregate savings compared to present and expenditures. So it sets up a stable system of healthcare financing. In terms of the dependence on the entire economy, I can't really think of a state-based bill off the top of my head. I could certainly get that for you, though, the answer to your question, because we have people that know there have been actually so many studies of state-based reforms over the years. It's been a very favorite position of politicians to say, that's an idea, let's study that. And then for the activists to come back and say, okay, this is how to study it, and then for someone to actually do the study. So you'd be amazed at how many different states have actually been looked at. What happened in Vermont, this is the previous questioner, in Vermont, the governor became a sort of capable and passionate articulate for single payer. He did not have a Progressive Party opponent. There might have been a backroom deal there where he came out for this idea in exchange for not having someone challenge him from the left. And he, Governor Shumlin then attacked the proposal for its strength, saying it would cost too much. It would actually, as this film showed, it would have, on its own merits, saved significantly. It would probably not have been a single payer because there would have been IBM, for example, corporations that refused to join and would use ERISA law to prevent them from joining. There would be all kinds of challenges with, what do you do with all the Adirondack people that need to go to Burlington for specialty care, and all the Vermonters that have to go to Dartmouth for specialty care. So there'd be issues in the details. So it might not have ultimately been a proposal for a single payer. It would have been very significant reform. It would have been a heck of a lot better. And I think that in terms of funding, an economist would end up arguing that it would be more stable to have a tax-based funding system than an employer-based and individual-based system if you're worried about insulating people from a recession.
Yeah, as a former Vermonter, I also feel compelled to point out that Vermont is a state with a population of, about 660,000 people. And, the saying, everybody in, nobody out, we ought to make the pool bigger. I mean, there are some people who felt that the pool in Vermont was just simply not big enough. Here in New York, we have a population of 20 million people. Much bigger pool.
My name is Paula Pliss, and I'm from Saratoga Springs. And my question is, what percentage does support single pay? Is it less than 3.5% across the nation and in New York State? And my second question is, why does New York State Health Act 4840 not advance to the Senate?
About 3/5 to 2/3, and poll after poll for about 6 years.
What do you mean?
Support the idea of national health insurance.
How many? What percentage?
60 to 65% consistently.
So why isn't it
Insurance companies,
yes.
Okay, so you're gonna. I want Dan to take the counterpoint. Okay.
Okay.
Because I'm gonna. So I was at a PNHP meeting many years ago, and I went to a great session by Len Rodberg about the Diogenes Project, which was the search for one captain of industry that would really explain the business case. And of course we have it now because Warren Buffett's partner has been saying that single payer is the answer, and Warren Buffett has been saying that the parasite that's dragging down profitability is healthcare costs. And Joseph Stiglitz has said that. But anyway, I was listening to this, and it dawned on me that most of us do not make our livings by owning stuff. I work. I don't go to work. I don't get paid. I get paid by the week, and you get a paycheck. I'm very, very privileged and have a colossal income by comparison to the patients that I really fret about. But this proposal would liberate so many working people. This proposal would liberate so many people who don't have the power of position, who don't have access to the senators and the congressmen. It would be profoundly, profoundly liberating for working people. And at that point, I kind of stopped worrying about the wealthy. I think they'll take care of themselves. And it would be good if the wealthy had to wait at the clinic and found that the clinic was under But there is at the same time a business case. I would say one of the things I enjoy about my practice is that I have such a disparate socioeconomic group. I have rich people, poor people. I have the wealthy lakefront residents of Brant Lake, Friends Lake, Moon Lake, and I have the self-employed loggers and the unemployed and the mentally ill. And the fact I can see them back and forth is very liberating for me. I think it's more satisfying. I want to make a point about the state of Vermont and its covered lives. The University of Vermont is making a lot of advances into New York State, and one would like to think, and I'd be careful, I'm speaking as an individual physician, not as a Hudson Headwaters employee, and I'm soon to be not the chief medical officer. But the University of Vermont is making a lot of inroads into New York State, and a lot of it is because they believe that their quality of care is good and they wish to be a tertiary or quaternary care center, as they call themselves. But some of it is they want our covered lives. And Hudson Headwaters is working cooperatively. I hope it's a very successful venture for that. But they need more covered lives because Vermont isn't big enough. And that's what this game is all about. And again, the best thing is a whole nation of covered lives. But certainly Vermont, I had sympathy for Shumlin because that was a difficult thing to pull off in a state like Vermont.
Why isn't the law moving through the Senate? Well, it has to do with power structure in the Health Committee, and the gentleman is going to be making a trip down there, and he needs warm bodies to stand and say this is unacceptable. When there's enough of that, enough of a wave of that kind of pressure, things can start to happen. He's stonewalling us.
It would also be nice to see the governor of New York State do something genuinely progressive.
Hi, my name is Debbie DeGennaro. I have a question. I read a few weeks ago about states forming a pool, New York, California, Vermont, for a single-payer system. How would that work, and how does that work with all the Medicaid dollars? And, if you have all these states with a pool and then you have your federal plans, how would that play out?
So, Quentin Young was a long time, one of the founders of PNHP and our longtime national coordinator, and he recently died in his 90s. And Quentin would simply say, you can't leap a chasm in 2 jumps. It won't work. We need a reform that is the definitive reform. This is the least increment. If you're looking for an incremental step to a single-payer system, in my opinion, we need a national health program, period. One step across that chasm. There's no increment less than that. The public option, for example, was an idea that took the worst of neoliberal ideology, that competition always works on some level,
and said that if we had a public insurer that competed on the insurance market with the private insurers, it would somehow magically reform the market through the magic of competition. Do you know insurance competition is the competition of who gets the wealthy and who gets the healthy? So they cherry pick, they fight over, the insurance company competition is who gets the people who won't get sick and will pay. That's the competition. A public insurer couldn't win that game. They'd end up with all of the poor and all of the sick. And then what would happen? You'd turn around and say, oh, look at that, it doesn't work. And where did that happen? Oh, it happened in Maine. It was called the Dirigo Plan, where they said we're going to have a great publicly backed insurer, and everybody can buy in at rates less than the private competition, and the benefits will be very generous and comparative, and the whole thing just went, right? So I think that the idea of there's some increment short of this, and Physicians for National Health program was designed in the name because we didn't really have a specific proposal in mind. Should it be a full-on national health system like in the United Kingdom, like you suggested? Should it be a single-payer system? I think what we've come around to the consensus from studying other nations is that if you want a system that guarantees health justice, basic access to everyone, then this is the least increment of change. And all these other things, there's no shorter step. And that makes it a difficult thing because then you have to fight for the demand. And
what if it happens?
It will be fraught with problems. This is why the Affordable Care Act, the Affordable Care Act, very, very good to have Medicaid expansion of 16 million poor people who would not otherwise have gotten Medicaid. Why do we know that Medicaid is better than nothing? Because the state of Oregon did something that they shamefully call an experiment. They couldn't afford to have everyone in Medicaid, so they had a lottery for who got Medicaid and who didn't. Then they followed the health outcomes of who got Medicaid and who didn't. And sure enough, it's better to have Medicaid for your health than to have nothing. So it's proven in health policy science by a public experiment in the state of Oregon, which, it was really an unethical randomized controlled trial, right? So we know that the Affordable Care Act was good to the degree that it got people some Medicaid coverage that they wouldn't get. But then, hundreds of millions of dollars were spent on what? Computer exchange systems to check somebody's homeland security status with their social security number, with their employment status, and it was this Byzantine mess that had glitches because it was a Byzantine mess, and a huge, huge amount of money went into this administrative apparatus that didn't go into care. And so what did the Affordable Care Act end up doing? It ended up guaranteeing that insurance companies would get taxpayer dollars. And that was like, they were selling a defective, unaffordable product already. Would you want to bail that industry out? So I think that in terms of this reform, there is something that's very hard about it, which is to contradict myself from a while ago when I said it's not that big a deal. You're talking about liquidating the health insurers. Putting them out, they can go do something else. They can sell another insurance. But when it comes to necessary care, it's not a legitimate way to make a profit, and you have to go out of business. And that's the reform, that's the demand, because we think the public should control it.
How many abuses of the system for profit? It's awful.
They say it's about 180,000 jobs in New York State that are related to in the insurance industry that will be lost. Freedom actually proposes that probably 200,000 jobs will be created because there'll be so much freedom created, an opportunity created for small business. Related to that question, the New York Health Act and the California Act process, for example, each of them, they're not coordinated together in any kind of way, and they raise their money in quite different ways. But they both would depend on getting waivers from the federal government to allow the Medicare and Medicaid monies to come into the system and be dispersed in a uniform way from New York State. And that's a tangle. No question, but that's what is proposed.
Hi, I'm Sarah Carpenter. I'm from Queensbury. I have 3 questions. I'll try to be brief. The first one is related to this bottle that I'm holding in my hands, which is worth $11,100. It's Imbruvica. It's the medicine that my husband takes every month for leukemia. And my question about single payer is, this is the only drug that will treat the type of leukemia and the particular mutation my husband has. I understand how single payer can negotiate the price when there's a brand name and a generic, but I'm interested in hearing how single payer may help bring down the astronomical, insane prices for these new life-saving drugs. So that's the first question. The second is, I don't know if we have any people in here who are opposed to single payer or skeptical about it, but I want to ask the question that is on many of their minds if they're here or watching, and that is, I hear the wait times in Canada are terrible. If we go to single payer, I'll never get my hip replacement. I won't be able to get the care I need on a timely basis. So that's question 2, is about wait times. And the third question is, it's my understanding that a lot of general practitioners support single payer, internists and GPs, but that a lot of specialists are opposed. Can you speak to why does that exist, that difference, and then why that is and what we would need to do to bring specialists on board?
Okay, so going backwards, the first answer is the study that was actually mentioned in the movie was done by Aaron Carroll. He's a pediatrician at Indiana who studied the physicians of the United States in a systematic way. He made a statistically representative sample of the American Medical Association master file of physicians. He weighted it by specialty so that each specialty was represented. He measured whether or not the doctors were in favor or against national health insurance. He did it over intervals of 10 years, and then he hasn't done it again. I'm sure he's not planning to, actually. But he showed over those 10 years, and now this is 10 years ago that it was published in the Annals of Internal Medicine, that 59% of American doctors in total want national health insurance, that the support for national health insurance had gone up pretty dramatically in every specialty, that the majorities in pediatrics, family medicine, internal medicine, psychiatry were huge, like in the 80-90% range, but the majorities were held all the way down, even into the surgical subspecialties. Some of the high-end radiologists, some of the very technical surgical specialties show the weakest support, but nevertheless a majority. So doctors actually have this idea, and I have my own anecdote, which is that when I worked for a big multi-specialty group that cardiologists dominated, and the cardiologists who are Republican donors would tell me privately, Andy, sooner or later it's got to happen, this is craziness. And a lot of it was just the injustice of what they were personally reimbursed when someone had no insurance, when someone, which is the full ticket because they could otherwise put them in collections, whether they had Medicaid, whether they had this insurance or that, and then their bargaining power with all those payers. All right, so the question about wait times in Canada. So in Canada, wait times are a big public scandal. And this happened pretty memorably. The neurosurgical ICU in Toronto was full. They sent somebody to Buffalo. They sent somebody to Detroit. It was on the front page of the Globe and Mail, and people were screaming. So the ethic in Canada is that our country should be able to provide these things. By comparison, here, if a kid has a snowmobile accident and the weather isn't good enough for the helicopter to fly, there may not be a neurosurgeon available anywhere in time. So our services are not there, the essential services, and yet it is not a public hue and cry that we expect the essential services to be there for every citizen. It becomes a private tragedy, so there's a major cultural difference. Therefore, in Canada, wait times are studied obsessively. So in Alberta, if it takes you 10 weeks to get your meniscus, your elective orthopedic surgery, then that gets put into a database and the letters pour in to the daily papers. And it's studied and it's tracked, and by managing the queue and by providing extra orthopedic surgery training in Alberta, they have gotten those wait times down. Huge public scandal in Canada. Now, by comparison, our wait times for insured customers are about the same. What happens to the uninsured who need elective surgery? Because in Canada, we're not talking about any necessary care. If you need an emergency open heart surgery, you need an emergency neurosurgery, you need an emergency spine surgery, you have an appendicitis, you go straight to the OR, right? So we're not talking about wait times for necessary care. We're talking about elective surgery, wait times that are a big public scandal in a system that I would argue is underfunded, way underfunded compared to us, less than half of what we spend in total. Actually, it's 2/3 of what we spend in taxpayer money. So an underfunded system has wait times for elective surgeries. What are the wait times for the uninsured to have your hernia repaired, to get your meniscus repaired? No one's measuring it because it's infinity. None of the uninsured are getting their elective surgeries, right? I was in Binghamton. My daughter had, visiting a friend of hers, and the dad pointed out to me, he goes, we noticed our neighborhood getting poorer over the years, and I have to say now that all my neighbors limp. And I thought, what an amazing anthropological observation about the poor,
Look at Saratoga, everyone's hitting like crazy.
But so the final question, the single payer proposal does not propose a pharmacare single payer. And I would add that Canada does not have pharmacare. There's a doctors group in Canada working hard to propose that they have a single payer reform like New Zealand has, where all of the drugs are bought by the government, and so that's pure up negotiation. And they point out that the Canadians would save all this money, and same method to the same discussion. Our proposal is not a direct proposal to take over or even what to do with pharma. It's an oblique threat that if the public actually controlled the health system, you guys would have to deal with us. And I think that when it comes to things like the cure of hepatitis C, which is now $100,000, but it's possible. And so as a public, I think we should talk about whether that's a priority. And I think the existing public health law would allow us to simply take over the factory, make the stuff, and cure it.
Possible, but not accessible to a lot of people.
Right. So that's right. It's not, no, but I'm talking about if, let's say the public decides we want that drug to be free to everyone with hepatitis C as a matter of public policy, right? If we decide that when it comes to a particular genetic mutation and a drug that targets it for a rare leukemia, and the science says it works, as a matter of public policy, we want to make sure that those patients get that drug. And we don't want that to be rationed. I think that's the public discussion we want to have. And the way it works now, sad to say, is there is rationing when there's no scarcity. Right. Because of access and ability to pay, mostly, but also because of corporate gains. So the answer is, the answer to the question is, this is not a pharmacare proposal. I wish it were.
Hi, I'm Sharon Stone. I'm from Minerva. I have a niece who lives in Canada, and I spent some time speaking with her about their health care. She's a certified counselor. Her services are not covered. She has to petition for families in crisis. She also says not everything is covered, and if you want better coverage, you pay for it. They have 3 supplemental plans available to them to buy so that they avoid the wait times. I also spoke to a young man who was attending the school I work at from Spain. He said everybody has care, but if you want the good care, you buy the policy. So I'm wondering, will there be supplemental policies available under a single-payer plan in the United States to get better care?
So in Canada, it's illegal to sell health insurance for things that are covered. So you can buy supplemental policies for things that are not in Canadian Medicare. In the HR 676 bill, all mental health care, for example, that would include counseling, is considered to be necessary care. And having that discussion, because we're talking about, this is a really weird way to talk about it. We're talking about finance reform, the reform of the finance system. And the idea that some of us have is that if we were able to successfully reform the finance system and have the public actually control the money and push it toward health, that we could make things better. We wouldn't necessarily make things perfect. It wouldn't automatically become a utopia, because as we can already see, we would have to fight for things like maybe we decide that social worker psychiatric counseling is something so essential to our communities that it needs to be now recognized, when in the beginning it was only psychiatrists and psychologists who were included. That was a mistake to leave the social workers out, and then that becomes a fight for public policy. Right now, under our current system, we're not anywhere near having that public discussion. They can talk about mental health parity, but when it comes to those without access and and serious and persistent needs, it becomes a really, really difficult minefield to get to any care at all. So I think that the question of this as a reform, we're not talking about delivery system reform. We're not talking about this is what it should look like. This should be the standard of care at the bedside. But you're coming toward the power to begin to make that transformation. There's a debate that I've had with many physicians at the American Public Health Association, for example, or at our annual PNHP meeting. They say this is nonsense. We need delivery system reform, and the only thing that will conquer it is if we have a VA for all. The VA should just take over the entire system, and all the doctors should be employees of the government, all the nurses too, because we need to control the delivery system. This is not that proposal. It's well short of that. And so you can begin to see why in Canada, when you have austerity budgeting and cutbacks, what's going to get funded and what's the ability of the doctors. So, for example, in Canada, the physicians were fighting for hepatitis C treatment recently. Pretty successfully, but then it has to be a real fight. It has to be engaged in public policy. So I think that's the beginning of the answer.
One more question? Okay, one more question.
One more question. First of all, I came into this room with questions, and they were answered in large part by Dr. Jolly's charts. Are those annual figures?
Yeah, annual figures, every year.
That's mind-boggling. Now I have a question.
Altogether, 110 million approximately.
Look at that.
I say those are annual figures. Altogether, they represent $110 million in saving for North Country towns and villages and school districts. 110 million that were thrown away. That we could reduce taxes, we could provide more services, we could, and of course everyone would be in.
Now, those are annual figures. Now I have a question for the room. Is anyone in here an elected official? Anyone at all?
I'm running for office.
All right. But see, we don't have all the right people in the room here.
But I just want to say that I've had some luck working with Dr. Jolly, and today we do have Bonnie is down at the Clifton Park Town Hall town meeting presenting with another person. So we have been out there doing this, and we've had a conversation with the supervisor of Clifton Park, and so we're kind of like taking these little steps. That's what we all need to do. We need to, go there in a group. I can't present in Clifton Park. I'm not in Clifton Park. We're going to do it locally in our town too.
This is a wonderful, eye-popping presentation here.
If anybody wants to have an instruction sheet on how to obtain those the Excel formulas and to use them, they're all available. I can give me your email address, and you'll be able to find it. I want every single one of you to go and calculate your local governmental costs and what it would save you.
This is a wonderful presentation because we're all taxpayers in here. We're all going to get sick, and we're all going to die someday. This has been a wonderful presentation. Thank you all.
Henry, before you take over, I got just one thing I want to say.
Okay.
You have to be alert, and you have to get involved. You take Betty Little's district, her senatorial district. What George is doing is huge, the effort that he's putting in. It could be groundbreaking. I think it will be. But Betty Little's district, 6 counties, 48 school districts, 21 villages, 2 cities, and 79 towns. Just her senatorial district. You need to be in touch with Betty Little. The gal to talk to in Glens Falls is Kathy Barton. Very nice lady. She'll take the time to sit down and talk with you. I wasn't able to convince her that this isn't going to cost more. And I think part of the reason is because the funding mechanism has not been put into the bill.
No, it's because it's government.
So nobody can answer that question, what it's going to cost.
The other thing I want you to just think about is what's going on at the federal level. The word now is that Mitch McConnell is going to do the same thing in the Senate with the American Health Care Act that Paul Ryan did in the House of Representatives. You need to be wary, and you need to get involved. Don't call Schumer. Don't call Gillibrand. You're preaching to the choir. Pick out a Republican senator who you think might listen to reason. You've got to be alert. You've got to get involved.
Okay, well, I want to thank you all for coming tonight, particularly those of you who asked questions, and of course the panelists. I find it mind-boggling. So much great information was disseminated tonight. Again, we will be having additional healthcare forums, and look forward to seeing you again.